global stroke fact sheet released in 2022 reveals that lifetime risk of developing a stroke has increased by 50% over the last 17 years, and now 1 in 4 people is estimated to have a stroke in their lifetime. And the topic of this scientific session is, the next topic is stroke management challenges and solution. The speaker of the session is Dr. Deepak Kumar Singh. Now I'd like to invite the chairperson for this session on the stage, Dr. Kartikeya Sharma, needs no introduction, renowned neurosurgeon of Prayagraj. Dr. Pankaj Kamra, he is an eminent neurologist with more than 20 years of experience. And Dr. Archana Ojha, assistant professor in the Department of Neurology, Motilal Nehru Medical College, Prayagraj.
So today we have Professor Dr. Deepak Kumar Singh. He is a MSMCH neurosurgeon. He is the professor and head Department of Neurosurgery at Ram Manohar Lohia Institute of Medical Sciences, Lucknow. His area of interest is endovascular neurosurgery and CV junction. He has so many papers as well as book chapters and presentations in various national and international conferences to his credit. Besides, he is the editor in as various capacities in multiple journals, and also has 3 patents of innovative spinal implants to his credit. Welcome, Dr. D.K. Singh. Let us hear from him. Thank you.
Good evening, Kartikeya sir. Thank you, Kamra boss. We all remember Kamra boss because when I was studying in MBBS, boss topped the UPPGMB entrance exams. And since that day, I still remember boss for his studious character. Thank you, boss. And good evening, friends. So my topic is stroke management challenges and solutions. In fact, when Pankaj asked me to prepare a talk on the stroke management, I really wondered what I should present. Because if you try to combine, like everything about stroke in 20 minutes time, it's not possible. So I particularly looked into, the challenges we are facing right now as an Indian. As an Indian, it's very important because the stroke management is entirely different ball game in our setup to that of the Western setup. And while preparing this talk, I came across the ideas, I went through the literature and I found out what are our challenges and what can be the solutions. So this topic is not very, my presentation is not very technical. It's going to be a very sort of IMA talk because I know I'm going to, speak before a mixed population, doctors from across all the specialties. And when I gathered data, I got an opportunity to present my work before the Chief Minister itself about the ideas while preparing this talk. So thank you, Pankaj and Varsha, for giving this topic to me. So in 20 minutes of time, I'll try to bring, what we can do as an Indian, what the IMA can do. So we all know about what is the definition of a stroke. It has been defined in 1970 by WHO as rapidly developed clinical signs of focal or global disturbance of cerebral function. And it is pretty same for last 60 years, okay? And if it is like continuously progressing, it is a stroke, and it subsides within 24 hours, we call it TIA. So there's not pretty much difference because one of the 5 TIA are going to develop a stroke in their lifetime. So we need to take care of the TIAs as well as seriously as we take care of the stroke patients. So it is the second most common cause of death. We all know about this, the introducer before myself has already talked about this. And incidence in India, if you look at this, is like 100 to 150 patients per lakh population per year. And it is a global estimate that by 2050, the 80% of the stroke people or stroke population, the incidence will be in only low, middle socio-economic countries, and India is going to be the forerunner among that. So, and every one of 6 Indians is going to be at risk. And in India and across the world, it is taking 1 life in every 4 minutes. And if you look at this, the risk factors, You will be surprised, because out of these 27 risk factors, if you look at 21 are actually modifiable. You can modify it, okay? Only six are non-modifiable. And out of these two, the hypertension and diabetes mellitus, we are the capital of diabetes mellitus and hypertension in the world. So we have to take care of these 21 risk factors, and if we can modify it, we can win it. I'm damn sure about that. So how we can? So Government of India in its 2019, they have given a vast list of measures how to prevent and how to treat stroke, and they have given their own guidelines for that. And there is a lack of, they have defined two strategies. One is population-based. Obviously, for any disease prevention, there are two strategies. One is population-based and one is high-risk-based. So in population-based strategies, what are the fallacies? The fallacies are that they try to, give us CVD prediction algorithm. But the CVD prediction algorithm in our country is not India-based. It's still taken from what we are reading in our, MBBS time, the Framingham Heart Study. That was done way back in 1960. And that we are trying to implement in our scenario for calculating, the incidence of a stroke or, the severity of stroke we can have in our lifetime. So how, and then when I came across, the literature, there is an interesting study by Beringer Ingram in India. This survey was titled The State of Stroke, a Survey on Awareness about Stroke in Urban Indias. That survey was done across 12 urban cities, the type 1 cities, among 5,000 people, 4,742 people. And you'll be surprised to know, even in the urban cities, it's not tier 2 cities, not Lucknow even. It's Delhi, Mumbai, Hyderabad, Bangalore type of cities, that 22% of the responders, only 22% of the responders were aware of the risk factors and symptoms of brain stroke. And 40% of them take brain stroke as a cause of concern. This is a serious issue. We are talking about 12 major urban cities only. We are not aware how this actually stroke happens, what are the symptoms. And if this is happening in the urban area, you can think of, the tier 2 cities and the villages. So that's a problem. And again, there was a study in 2010, the impact of media on community awareness of stroke warning signs. And they have done, intense campaign in Texas. They have done in, 2 cities, they have done an intense media coverage of, stroke prevention programs and everything. And they have noted in 2 years' time, there are 82% more responses to 911 when they have identified any stroke symptoms. So there are 82% more response. On daily basis, we are seeing, on the cigarette packs, the cancer prevention program is going on. But about a stroke, there is nothing. You will not see, or you are not seeing any, media coverage regarding the stroke prevention programs or how you should identify a stroke and where to go if a stroke happens. So that's the current scenario. And Indian government actually has run a program in across 250 districts, and they are trying to bring the ASA Bahus, the ANMs, and the local PSCs team into the frame. But I went through, the guidelines given by them, the 2019 guidelines. There is an exhaustive list that they have given, the work they have assigned to the ASA Bahus and ANMs. It's such an exhaustive list. I stopped typing about these 5 columns. Because the ANMs, ASA Bahus, they are not qualified enough. It's not going to work. They have assigned, the stroke identification, where to call, to ASHAs, to ANMs. It is not going to work. It's not possible, at least as per my understanding. So what we can do? My friends of 35th batch, Pankaj himself, they are, avid cyclists. Kamra boss himself. I'm seeing their photographs on daily basis on the mass media. What we can, on the social medias, what we can do, we can exercise, first thing. I'm damn sure in our clinical practice, we are so busy, we don't pay any attention to our bodies. We are not taking 30 minutes of our life daily for, for making our life better, for preventing these diseases. So what we can do, we can definitely regularly exercise. And one important thing is childhood obesity. We should not ignore it. You see, I have seen the parents saying that, okay, my boy is obese, but let him eat chocolate, let him do whatever he wants to do. When he came into 80s, become, adult in 20s, 30s, it will go, he will manage. But recent studies have shown it is actually the childhood habits which are going to do or decide how your arteries will be, how your brain will be in your adulthood, in your old age. So you have to take this thing into your mind that the childhood obesity or childhood habits are going to decide his future. Okay? Okay. So I think most of us are not aware that Government of India actually has given his age-specific fitness protocols. At least I was not aware of that. On the Sports Authority of India, the Ministry of Health and Family Welfare and the Sports Authority of India has given age-specific fitness protocols. I was not aware of that. And I am damn sure no one among us was aware of this also. They have decided what type of exercises, they have actually written it. And it is available on the internet that how much of exercise before 18 years, from 18 to 65 years, and after 65 years. It is there, but we are not following it. Second thing, actually that I have thought, but when I went into the literature, I found it was already done, but was not implemented. There was a program that was called KIDS, that is Kids Identifying and Defeating Stroke Program. So, again in US, among the non-Hispanic and the Mexican population, in 12 districts, what they have done, class 6, 7th and 8th standard children, they have taught them how to identify stroke and when to call 911. They took 50-minute classes every year, 4 classes, to these standard people, to these standard children. And you were amazed to know the children are such a good learner that the response time in these districts was like 5 times. Children have identified their grandparents' stroke and they have responded. So why we cannot adopt? My 10-year-old children is learning computer science. Okay? So why he can't identify, that, yes, my grandfather is having problem in speech. He is developing weakness on one side. He has imbalance. He can call. Okay? So that is one thing that definitely should be looked upon. And in fact, that is one of the major recommendations, major things that I have told to the authorities, that you should implement a chapter about the identification, the prevention and identification, and when to call, the health services among the basic curriculum part. And that can be done. It's a very cheap method. Just dedicate a single chapter to 6th standard, 7th standard, 8th standard, how to identify stroke and when to call emergency services. That can be done. Very cheap method. Okay? You need not to go through ASHAs, ANMs and everyone. You can do it through basic curriculum. Okay? So these are recommendations that I am very hopeful it is going to be very soon. Make the stroke identification a part of basic curriculum, prevention strategies, risk identifications, emergency treatment, and when to seek medical opinion. This can be done. A 10-year-old child can do it. I am damn sure about it. Second thing, take physical education seriously. Even in my family, the day where, when the physical education classes were there, I was not serious. I used to say to my family members, अरे ठीक है रहने दो, आज तो क्या है ना कि आज केवल पीटी की क्लास है, आज रहने देते हैं, इसको नहीं भेजते, शाम को मैथ को उसको ट्यूशन जाना है. We never take physical education classes seriously. And that culminates in our child's mind also. Okay? He also never take it seriously. Because for him, it's only, sort of time wasting. Playing is a sort of time wasting. It's not about making his life better. So you have to teach him that this is about your life. This is about making your life better as your rest of, subjects are going to be. Third is media coverage. It's still lacking as far as the stroke is concerned. They should be taught, people should be taught to learn about the fast, and they should be taught them when to refer the patient, that time is brain. Every minute of a stroke patient is losing like millions of cells. So time is brain, he has to remember, everyone has to remember through the media coverage. And this is again, a very innovative idea that came into our mind. That why to go for print media or, social media? Most of the people are actually the hypertensives and the diabetics. Why don't you print it on their, drug wrappers? They are taking it on daily basis. This is not the original picture. I have modified it actually. Why we cannot put, the warning signs, where to call on their drug packages? They are going to take their drugs twice or thrice a day. So definitely every time they will see this, कि ठीक है, मेरे मुंह में टेढ़ापन आ रहा है, मुझे बोलने में दिक्कत हो रही है ना, मेरे हाथ पैर में कमजोरी आ रही है, मुझे कॉल करना है. And if he'll see this 3 times a day, definitely he will remember it more like from any newspaper or from any media. So definitely this can be done. It's a very cheap method. So you are also going to see this in coming future. I am damn sure about this. Okay, so this is about the population-based strategy. Now I am coming to the high-risk strategies. Okay, we all know about how to manage. The physician friends are knowing the hypertension, diabetes mellitus, tobacco uses, the atrial fibrillation, mitral stenosis. One thing I have put in note on this cache just to make this topic more interesting. Alcohol, antiplatelets, everything. So as far this carotid artery stenosis is concerned, in 2019 guideline, if the patient carotids are more than 70% stenosed, and if he is symptomatic, he should be offered endarterectomy or stent placement. But if he is asymptomatic, obviously he should be referred to the expert centers where the peri-procedural mortality is less than 3%. They only can take a call. It's very clearly specified in the Government of India protocol that it should be done by a center where the peri-procedural mortality is less than 3%. Okay, so how it is done? I think it is not working. You just can minimize this window. I can play it right from desktop. Okay, now it is there. Okay, so this patient is, you can see, like this whole IC has gone at its origin. So almost 90%. A wire is passed. Okay, I will fast forward it. A wire is passed, and you can see there is a filter that is placed here, to prevent the cardioembolic events. And a stent is being put here after 1 and 2 angioplasty, balloon angioplasties. The stent was finally placed. Okay, sorry. The stent is opening up, it is placed, and that is the final run. And so you need to take a call depending on your expertise level and the symptoms of the patients. Now, coming to the management. Obviously, both the TIA and stroke should be taken seriously. Every person, as you are learning about CPR, they have to, I can take, I think, 5-10 minutes. Okay, so they have to learn to identify the stroke symptoms. In Hindi, it's dekhna, dikhna, haath, pair, bol, chal. And any patient who presents with transient symptoms, okay, he should be treated as a case of TIA unless proven otherwise. CT, MRI, and vascular imaging should be done as per protocol. He should be started on antiplatelets as per protocol, obviously. And every patient of TIA should be admitted. He should not be sent home. Okay, if the patient came to you and he says, sir, ऐसा करके हुआ है मुझे, just don't send him home on antiplatelets, admit him, work up. Because 1 of 5 patients are going to have stroke in their lifetime, and the chances of a stroke are most high in first 90 days. Okay, so this is the drug protocol. I am not going into the detail. Unfortunately, in India, only less than 1% of the TIA patients report for evaluation. That's the reality. Okay, so coming to the specific treatment. This is again a matter of concern for us as an Indian, because the first 3 hours and extended 4.5 hours window is the most crucial one. Because this is the time where we can start our thrombolysis therapy in ischemic patients. 80% of the stroke patients are actually ischemic patients. So this time frame has to be shortened. And this we can shorten as a citizen, we can do it together only. Okay, not a single family can do it. Unless, I'll put in the last slide, what are the problems. So these are the guidelines. Patients eligible for intravenous RTPA should receive intravenous RTPA, that is class 1 evidence for this. And the recommended guidelines now has extended the mechanical thrombectomy period up to 24 hours. But yes, there are many ifs and buts in between. But the mechanical thrombectomy period has been extended up to 24 hours. Okay, that one should remember. So if 4.5 hours passed and patient has come to you and he said now he has developed a stroke like 6 hours before, just don't put him, without any treatment. You have to refer him for mechanical thrombectomy, where he will undergo other procedures like MRI, where the volume will be decided, and accordingly he can be a good patient for mechanical thrombectomy. So for MT, the extended period is now 24 hours. That one should remember. Next problem. A CT scanner is right now functioning in almost every district of India. Every district, even in the district hospital, CT scanners are working. But how many CT scanners in the district hospitals in the night can actually report that there is a hyperdense MCA, or there is a subarachnoid hemorrhage? No one can. Only in urban cities, urban areas, it can be done, but not at district level. In rural setup, it is not possible. So what can be the solution? The solution can be that government can make a network-based reporting system, and they have to take control of it they have to take control of it, because only government can give good incentives and make radiologists available for 24/7 reporting. And if this can be identified in the middle of night in 30 minutes, this can be treated. But if he comes to you in the morning, everything is gone. Okay, so the solution, I am seeing it in near future. This is going to happen. Again, these are the two drugs that are right now approved by the government of India for thrombolysis. One is RTPA, that can be given up to 4.5 hours. And second is TNK, the tenecteplase, that can be given only for first 3 hours. The extended time frame is still not recommended by government of India for TNK use. But for first 3 hours, we can use either of these. But in 3 to 4 hours, we can only give etlipase. Okay, and you can calculate the dose by your own, or you can use any web-based calculator. It's up to you. The problem is, you must be wondering why I have put this. The cost of one alteplase injection is like 45 to 50K, and for TNK it's 25 to 30K. For any normal weight patient, we are bound to use 2 vials of alteplase. Okay, that is going to cost like 90,000 rupees. A low middle income patient in the middle of night in first 3 hours cannot afford this. I'm damn sure about it. And believe me, if we make everything free to these patients, like if we made TNK freely available to every patient. And if every patient is eligible for thrombolysis, only 10 to 15% patients are eligible for TNK, by the time they reach the hospital. Then the cost will be only 3.5 Rafael. This will be the cost that Government of India is going to bear if we make every TNK free of cost to every patient of ischemic stroke, considering the incidence of 100 patients per 1 lakh population. It's not a big cost. It can be done. And you see what is happening. You can see the GDP data. Though the actual cost is, actual cost that is being spent on health is increasing, but if you take it in percentage, in 21-22, it is all 0.6%, and in this budget, it is only 0.35% of the total GDP. That is actual expenditure. That is 0.35%. And if you take, the Ayushman Yojana, they put a very good package for MT, for thrombolysis and mechanical thrombectomy. But the problem, no center, at least in RML Lucknow, and I'm pretty sure that is happening in Allahabad and across all major cities in India, Ayushmans don't work in emergencies. They are not a cashless scheme. Patient has to put his card, patient has to give his IDs, and it start functioning in 16 to 24 hours. And by that time, everything is lost. So that is one thing that can be worked upon. Government actually has put a very good amount of money for doing this mechanical thrombectomy. But there is no emergency provision. It's not a cashless scheme. That is the problem. And Ayushmans don't work in emergency. They take time. And that is one recommendation that I have put before. That it should you have to make it a cashless scheme. Otherwise, we are not going to, to work upon the stroke patient. Now, when the thrombolysis period had passed and patient is there either for the bridging therapy or for the extended time period, these are the armamentariums that we can actually use for doing the aspiration or for stent retrieval. So this is how, there are two techniques, and just for sake of demonstration, this is a demo video. There are two techniques. This patient landed up in the night, has left MCA blockage, and this is the technique how you can, reform your catheters while going inside. How to fast forward the video from here. पीछे वाले में जाओ ना, कहाँ यार, ऐसी हाल है तुम्हारा, कैसे वीडियो आगे बढ़ेगा ये? हाँ, रुको. Okay, so this is how you go inside with your micro catheters, aspiration catheters, and long sheaths, and you can either directly aspirate by adapt technique, that is called direct adapt, or the Solumbra technique, where you can pass a stent through the clot and you can actually pull down the whole thrombus with your stent retrievers. So that's the demo video, and this is the actual scenario where the patient landed up in the middle of the night with right-sided hemiparesis, and run this video. Okay, I'll show you. So this is the first run, where you can show the ICA is gone there. There is no distal filling, it's TICI 0, and then we used a stent retriever, and the clot was removed. Unfortunately, it's very difficult, fast forward the videos on this platform. And this is the final run. Now you can show, you can see this ACA and MCA, very good filling. We achieved TICI 3, and patient was sent home with only slight paresis in the right upper arm after 48 hours. And this is, I have put pictures only. So this is again a case of the COVID times. The patient 65-year-old gentleman came to us in even V1 M3 condition. This is a posterior fossa stroke. You can see the vertebral is gone. There is no vertebral. We tried to aspirate it, but posterior fossa strokes are very, notorious for atherosclerotic plaques. So we did a balloon angioplasty, and we put up a stent, and this is how the final run came up, and there was no additional infarcts. And this is the picture of this patient. I asked for his picture, and he sent me on WhatsApp like 7 days before only while making this presentation. He's all good. He was discharged on tracheostomy, but right now he's completely independent. Obviously, he's on dual antiplatelets. And hemorrhagic stroke, I only put a single slide. So as far as the surgical indications are, concerned, the government of India has given, I don't go into stage 1 and 2 trials. They have said, if the patient condition is deteriorating and there are signs of herniation or midline shift in the CT scan, okay, and his GCS is more than 6, and before this event, if he was not dependent on others, you have to go for surgery. That is the government of India guidelines. Okay, they are very straightforward. If patient is not dependent on others, if presenting GCS is more than 6, and there are signs of neurological deterioration with radiological evidence, you have to decompress it. That is one of my another favorite topics, that is subarachnoid hemorrhage, but only 5% of these patients of stroke actually make up this. So this is one case. There is giant medial posterior choroidal artery aneurysm that is not amenable for the neuroendovascular treatment. So I operated it through the Poppins approach. It was clipped and patient was all fine. A large ACOM aneurysm is what required. Depending on the location and the morphology of the aneurysm, you can either choose for a flow diverter or the newer, the contour devices. The contour devices, this is large ACOM aneurysms. I'm concluding in 2 minutes. Okay, this is a large ACOM aneurysm with a wide neck. You cannot, put your coils here without putting an assistance over the neck. So if you put a stent, the patient has to be on dual antiplatelets for lifetime. So there are new devices in the market. They are called contour devices or wet devices.
Please cut short the talk because...
Sure, sir. And then you can, get away. So again, rehab services are very important. Unfortunately, in India, only 1.8% of the stroke survivors seek for rehab services. And the basic problem, obviously, is the cost. So this is my final slide, and this is the scenario. रात के 11 बजे घर के 65 साल के बुजुर्ग की आवाज़ चली गई. एक हाथ पैर ने काम करना बंद कर दिया. घर वाले रात में हाथ पैर की मालिश करते रहे. सुबह हॉस्पिटल पहुंचने पर डॉक्टर साहब ने बताया कि खून का थक्का जम गया है जो तार से निकालना पड़ेगा. 2.5 से 4 लाख का खर्च बता रहे हैं और ठीक होने की गारंटी भी नहीं है. डॉक्टर साहब कह रहे हैं कि हो सकता है जीवन भर अपंग अवस्था में ही सेवा करना पड़े. And that is the actual scenario. And you can have your answers from this thing only. रात भर सेवा करते रहे, they are ignorant. They need finances. They have to accept that he may not be cured. They need assistance for their lifetime. और अगर हम इसमें जोड़ दें कि आपको इस रोगी को दूसरे हॉस्पिटल में ले जाना होगा because we cannot do mechanical thrombectomy. I am not sure how many stroke ready centers are here in Allahabad. In Lucknow, it's only 3. Okay, so you can add this competence also. So we have to find these answers, and then only we will be able to to answer all the questions regarding the stroke challenges. Thank you so much.
Yes, the message for this stroke management is only 3. You have to report to your doctor whenever you feel such symptoms. And initial 4 hours are crucial for your life. TPA is one of the very good drug, and it has got given the 80% good results. So you must carry all these patients as early as possible to your neurologist. Second, what the Dr. Deepak is doing, the stenting and clot retraction from the cerebral arteries as well as the internal carotid arteries. I can show, not in Allahabad, but in the western countries or even in the metropolis, patient of the stroke is going back to his house within 48 hours, walking, talking. So we need to emphasize that we should manage the stroke as early as possible and as effectively as much. Second is the one, maybe the paucity of the time he could not mention. In cases of the hemispheric stroke, where you find that one of the hemisphere has gone, the decompressive craniotomy is one of the best surgical treatment options. More than 50% patients survive, and about 30 to 40% patients come back to the near normal life after the decompressive craniotomy. These are the few points which I wanted to add in this, and I asked the audience to ask Professor Deepak any question.
In one of your slides earlier, you have shown the hyperdense artery sign as a sign of ischemic stroke, but unfortunately that's not seen in most of the cases. Now if you see from that standpoint, as you said, 80% of these are ischemic strokes. If you need an MR, then if you see the Indian scenario, as you said earlier, we are looking at India-centric solutions and situation-specific. So if he gets an MR appointment...
I got to a point. See, only in 30% of the cases you see hyperdense MCA sign. So as per ASA guidelines, you need not to see, hyperdense MCA, you need not to see anything. So in stroke patient, the CT scan actually is done to rule out hemorrhage, And if the patient lands up to you, you only require two things. You require one RBS and you require a CT scan to rule out hemorrhage. And if it is not there, the hemorrhage is not there, where the hyperdense MCA is there or not doesn't matter at all. You have to initiate thrombolysis. So that's one thing. If hyperdense MCA is there, it means there is a large vessel occlusion. So these patients are actual poor responders of the thrombolysis because there is a large vessel occlusion. And you have to put these patients for a bridging therapy. I mean, with thrombolysis, they have to put for mechanical thrombectomy. Because these large clots, they will not go with thrombolysis alone. Hyperdense MCA is seen only in 1/3 of the cases. CT scan goal in stroke patients is just to rule out hemorrhage, that it's not a hemorrhagic stroke, it's an ischemic stroke. That's it.